call upon Dr. Professor Max Haerle, if I pronounce it right.
Perfect.
Yeah. He will tell us now and improve our knowledge on how to salvage DRUJ.
Yeah, thank you, Sanj, for helping me to explain all these problems already. So it's really a headache to do that in 8 minutes. The anatomy is done. We have said if the distal radial ulnar joint is not solvable, then we have several options to go for. The options are Sauvé-Capenghi, Dirac, and Bowers in essential. The question is always about what we do with the TFCC. Dirac procedure, resection of the ulnar head, watch out to refix the TFCC to the capsular tissue. This is the surgical technique. There are several approaches proposed. I just want to tell you that in all cases, the soft tissue balance is one of the most important things. But going too deep in these details is a problem. That's a case of a long one, and you make the resection. This is a case of Riccardo Lucchetti, and a very good result in late things. Dirac procedure is most effectful and mostly done in rheumatoid arthritis. Very good indication for this one. Important is to retain the ulnar styloid and its attachments. Going to the next thing is the Bowers techniques, which was fallen in disgrace for many, many years. We have some kind of revival of Bowers procedures, hemiresection and interposition of the capsule. On one hand, retaining the ulnar head in its position, on the other hand, doing an interposition. I like this more and more. I think it's a good technique. Technical points are different. This is a case we had tried to refix the TFCC. We were not able to refix it. Chronic pain and osteoarthritis, cartilage gone. We did this Bowers procedure, and this is after 2 years, moving quite well, rotating and in almost all directions. Make a long thing short, we run. Next procedure is Sauvé-Capenghi. We have already right now heard about this. We can do that openly. There is a technique which was proposed by Alberto Luc from Barcelona. Just resect, fix it, resect it, turn it around and reposition it in a slightly subluxated position to have the ECU tendon in the right position. Watch out for stylocarpal impingement. Arthroscopic technique, which was developed also by Lucchetti and Atzei, is an arthroscopic technique where you do practically the same, resect the DRUJ and then arthrodese it by minimal invasive surgery. Doesn't change a lot, I think, and the operation time is more or less the same. Give good results at the same time. The main problem of all these procedures, which are all good for certain cases and individual cases, is the instability of the ulnar stump. We have already heard that there is a big problem there, and as soon as you load it, then you get this impingement at the distal radial ulnar joint, and especially if you resect the heads, then you go to destabilize that even more. This is what happens in Sauvé-Capenghi. There are different techniques of stabilization. First of all, the remnants of the distal radial ulnar joint capsule has to be refixed. This is one of the most important things, and you can try different techniques of stabilization. The instability is not only due to the local capsule problem, but the instability often is also due to injury to the interosseous membrane. The interosseous membrane is then a key and probably creating the insuccess of the primary repair of TFCC and secondary osteoarthritis. So that may be a problem which is going beyond, but there are different types of instability. Naturally, this transversal instability is what we are most fearing in these operations. And especially in Dirac, this instability is the most feared complication of all. This is why Dirac operations is recommended for patients with low demand, as in rheumatoid osteoarthritis and not so much for load-bearing patients. So in beyond all these options, Kappanji and Bowers in my hands give quite good results, and I use them quite frequent, and Dirac in my hands mostly for rheumatoid patients. So prosthesis. There are several prostheses on the market, as we heard already. There is a hemiprosthesis, a total head prosthesis, and a complete coupled prosthesis. Hemiprosthesis is something which has very low numbers, as Professor Kakar did just tell us, and we don't know really on a large scale, but the ulnar head prosthesis has more acceptance. Indications is the revision of instabilities and maybe a primary solution or a secondary solution. The most important thing is here the capsular soft tissue balance to avoid subluxation of the prosthesis, and this is soft tissue is in the rheumatoid arthritis always a problem. The interosseous membrane I have already mentioned, and there are long-term studies out which prove that this prosthesis is working, in contrast to many other things we have heard about prosthesis. Normalizing stability, very good long-term function after 11 years, and even better results after 30 months with primary implantation. That means you can do secondary, you do first Kappanji, and if it's not working, you can do still a prosthesis. Long-term results also, this one is an example of a long-term results. The problem with the prosthesis is recurrent instability, migration of the head into the radius, periprosthetic fracture, loosening, or ossifications. All kind of problems we have with prosthesis also here can happen. This is why I am a little reluctant to use that as a primary solution, but people say you can. If you are in greater difficulties, especially if the interosseous membrane is unstable and you have a high instability, the so-called checker prosthesis, which is a coupled prosthesis, gives you a secondary stability in between these joints. Seem that also long-term results are giving confident results, but series are still limited. This is how it looked like. So prevention of osteoarthritis for me is the most important thing. So these were the talks before. Painful osteoarthritis, older patient, Bowers, younger patients, or Kappanji. For younger patients, we can consider ulnar head prosthesis. Painful instability after resection, yes, then ulnar head prosthesis can go. Instability after prosthesis, then the checker prosthesis would be a solution, and remaining instability, pain after checker, is the desperation solution. One bone forearm. I hope never you have to do this. Thank you very much for your attention.
Thank you, Max, very much for the very enlightening, difficult problem. I think maybe we can